So, hello, dear students. Today we'll discuss about the bleeding in early pregnancies. Mhm. So, about definitions. As you can see, any vaginal bleeding before 20 weeks period of gestation is defined as early pregnancy bleeding. In this slide, you can see it's the causes of bleeding in early pregnancy. It may be abortion, it may be ectopic pregnancy, and molar pregnancy. So related to pregnant state, it's abortion, ectopic pregnancy, molar, and implantation bleeding also. So associated with the pregnant state, it may be cervical lesions like ruptured varicose veins. In this picture, you can see the cervical erosion in the external os of the cervix. You can see this cervix is a vaginal wall, and you can see this kind of image during the speculum. In this case, you can see the cervical polyps. It's also located inside of the cervical os in the endocervicitis. We have endocervicitis, and with polyps, this growing through the external cervical os. In this case, you can see it's a malignancy cervical cancer. In this case, you also can have a bleeding during the cervical canal. So pathology. Hemorrhage into the decidual bacillus, necrotic change in the tissue adjacent to the bleeding, detachment of the conceptus. The above will stimulate uterine contraction, resulting in expulsion. If it's in baby, then you are not pregnant. So, what are you abortion? Abortion. Termination of pregnancy before the fetus is capable of extrauterine survival, 20 weeks or 500 grams birth. So we can have several types of abortions. With a spontaneous abortions, it's maybe isolated. With a threatened abortion, inevitable abortion, complete abortion, incomplete abortion, missing abortion, and also with septic abortions. We also have a recurrent abortions also. As you can see in this image, we have a threatening abortions, inevitable abortion, and complete or incomplete abortions. So induced abortion, we have two types of induced abortion. It's illegal abortion and illegal abortion. Illegal abortion is mean if we're doing in the hospitals by medical or surgical abortions also. Etiology. This may be genetic factors due to some genetic disease, endocrine and metabolic abnormalities, and infections. So, anatomic abnormalities. In these pictures, you can see abnormal anatomic in the uterus with two uterus, and we also have this kind of pathological anatomic abnormalities. Immunologic disorders, it may be autoimmune disorders, autoimmune disorders, anti-fetal antibodies, maternal medical illness, blood group and incompatibility, PRO, preterm rupture of membranes, environmental factors, and unexplained. So, what is the mechanism of miscarriage? Before the 8 weeks, the ovarium surrounded by the villi with the decidual coverings. It's expelled out intact. Sometimes the external is fails to dilate so that the entire mass is accommodated in the dilated cervical canal and is called cervical miscarriage. So, as you can see by the ultrasound research, you can see this is a blighted oval. So 8 to 14 weeks. Expulsion of the fetus commonly occurs leaving behind the placenta and its membranes. Beyond 14 weeks, the process of expulsions is similar, so that of a mini labor. The fetus is expelled first followed by the expulsion of the placenta after a varying interval. So, threatened miscarriage. It's a clinical entity where the process of miscarriage has started but has not progressed to a state from which recovery is impossible. So, we have different types of threatened miscarriage. In our standards, in Uzbekistan standards, we say threatened if we have only the increasing of the tonus of the uterus. This way, we will have only pain. only if we. But if we have a bleeding, in this case, we say the beginning of abortion. So threatening, it means if you have a pain. But in other books, they say if it's threatening, it means if we have a also if we're bleeding also. So clinical features is a short period of amenorrhea corresponding to the duration, mild bleeding, mild pain. Per vagina, you can see the cervical os is closed. Pregnancy test, you can see a positive HCG. So serum progesterone, yeah. So management, you have reassurance, breast, drug. You can use a diazepam, 5 milligram, and you must repeat others laboratory diagnostics. So, inevitable abortion. So, what does it mean? It's a clinical features, short period of amenorrhea, heavy bleeding accompanied with a close may lead to shock. Severe lower abdominal pain. Per vagina, you can see open cervical os, and pregnancy test, you can also find the HCG is positive. Non-viable fetus and blood inside the uterus by ultrasound research. Management, you can do a fluids like a blood. You can use it if we have a decreased count of the hemoglobins. Meturgine, 0.2 milligrams intramuscles. Evacuation of the fetus. You can do is medical due to some medicines, and also you can do is like a surgical. It's a by a curettage. So complete abortions. It's expulsion of all products of conceptions, cessation of bleeding and abdominal pain. Perivaginal closed cervical also well closed, external cervical os. Ultrasound is you can find is uterus is empty. Management, you must also do a control ultrasound research after the 1 or 2 hours. You can also do anti-D gamma globulin. When we do anti-D gamma globulin, if we have RH minus in the pregnant woman, yeah, you must do it for prevent the other RH incompatibility in the next pregnancies also. So you can see it's incomplete abortion. What does this mean? Incomplete abortion is mean in which some part of the tissue stayed inside of the uterus. That's why it will be cause of the bleedings. So in this case, you can see the complete abortion. We don't have any tissue inside it, so you don't need to manage it. You just check it by ultrasound research. But if we have incomplete abortion, you must manage it like a surgical abortion. So misabortion, what's mean? So it's a gradual disappearance of pregnancy symptom signs. Brownish vaginal discharge, milk separation. Pregnancy test negative, but it may be positive for 3-4 weeks after the death of the fetus. By ultrasound, return absent fetal heart pulsation, complication is infection and DIC, disseminated intravenous coagulations. Treatment, wait 4 weeks for spontaneous expulsion, evacuate if it. Spontaneous expulsion does not occur after 4 weeks, infection, DIC, managed according to the size of the uterus. If uterus less than 12 weeks, dilatation and evacuation. If it's more than 12 weeks, you must try oxytocin or PGS. So septic abortion, an abortion complicated by infection. Symptoms, it's a signs is abdominal pain, fever, vaginal discharge. It's a smelling, like full smelling. Yeah, signs. It's a sick looking, fibrilline or jaundiced. A tender uterus, offensive vaginal discharge or bleeding. Cervix is usually soft and may be dilated. So, with clinical grading, grade 1 is the infection is located in the uterus. Grade 2 is the infection spreads beyond the uterus to the parametrium. In the grade 3, it's the most complicated type. It's generalized peritonitis or endotoxic shock of duodenus or acute renal failure. In this case, you can find the inflammation in the abdominal layers also. That's why we call this peritonitis or pelvic peritonitis. So complicated, it's a hemorrhage, peritonitis, pelvic abscess, endometritis, septicemia, septic hemorrhagic shock. Late, it's maybe PID, pelvic adhesions, and second infertility. Management. So this is resuscitations, IV fluids, insert uterine catheter, blood grouping, cross-matching, and commonly we're using antibiotics. We must use several types of antibiotics. So, prophylactic anti-gas gangrene serum of 8,000 units and 3,000 units of anti-tetanus serum. Evacuation at hemotonics. Recurrent miscarriage, defined as three more or consecutive pregnancy losses. Other names is habitual abortions, habitual miscarriage, recurrent abortion, or recurrent miscarriages. Etiology can be established is only 30%. It may be genetic factors, endocrine factors, anatomic causes, congenital anomalies in competencies, infections causes, and immunologic problems. Ectopic pregnancy is one in which the fertilized ovum is implanted and develops outside the normal endometrial cavity. It's ectopic pregnancy. It's not in the uterus. So as you can see, this is the types of the ectopic pregnancies. It's located in the fallopian tubes. Commonly, you can find it's more than 98% of the ectopic pregnancy located in the fallopian tubes. It's common is the ampular part of the fallopian tubes. As you can see, this is the uterus, bowel, and this is the fallopian tubes. In this case, we have ectopic pregnancy, 5-week gestation. It's a clotted hemorrhage. In this case, we have ruptured ectopic pregnancy in the fallopian tubes. Increase due to PID, use of EUCD, intrauterine devices, tubal surgeons, and assisted reproductive techniques. Range from 125 to 250. Average range is 1 in 100 normal pregnancies. Late marriage and late childbearing, 2%. ARIT 5%. Recurrence rate 15% after first, 25% after second ectopic pregnancies. You can see the types of ectopic pregnancy. It may be interstitial, it may be cervical, it may be isthmic, ampular, intraligamentous, infundibule, tubal. It's a ovarial ectopic pregnancy and abdominal ectopic pregnancy. Etiology is the tubal factors, zygote abnormalities, ovarian factors, exogenous hormones, and other factors. Fate or tubal pregnancy, a tubal mole. The gestational sac is surrounded by blood clot and retained in the tube. This may remain for a long period in the tube and form so-called, or they may be gradual absorbed. Tubal abortion. This occurs more of ovum had been implanted in the umbilical portion of the tube. Separation of the gestational sac is followed by its expulsion in not the peritoneal cavity through the tubulous tube. Rarely, reimplantation of the conceptus occurs as another abdominal structures leads to secondary abdominal pregnancy. Fate of tubal pregnancy. 3 is the tubal ruptures, more common if implantation occurs in the narrower portion of the tube, which is the isthmus. Rupture may occur in the antemesenteric border of the tube. Usually, profuse bleeding occurs. Intraperitoneal hemorrhage. If rupture occurs in the mesenteric border of the tube, broad ligament hematoma will occur. You can see it's a broad ligament hematoma, and you can see the ectopic pregnancy in the permeable part of the fallopian tubes. Clinical features, it's acute ectopic, unruptured, and subacute, chronic or old. Early symptoms are either absent or subtle. Clinical presentation of ectopic pregnancy occurs at the mean of 7.2 weeks after the least normal menstrual period, with a range of 5 to 8 weeks. The most common presenting symptoms that are suggestive for AP. Clinical triads. It's amenorrhea, it's abdominal pain, and abnormal vaginal bleedings. Signs. The patient took quiet and conscious, perspires and looks blanched. Pallor, features of shock, abdomen feels tense, timid, and tender. Pelvic examination reveals blanched, white vaginal mucosa. Uterus seen normal in size or slightly bulky. Extreme tenderness on fornix palpation or on movement of the cervix. No mass is usually felt through the fornix. The uterus floats as if in water. Unruptured tubal ectopic pregnancy. Symptoms. Presence of delayed period of spotting with features suggestive of pregnancy. Uneasiness on one side of the flank, which is continuous or at times colicky in nature. So the next signs is a uterus is usually soft, a pulsatile is small, well circumscribed, tender mass may be felt through one fornix separated from the uterus. Chronic or old ectopic pregnancy is signs, this is amenorrhea, lower abdominal pain, and vaginal pregnancy. We also have another signs, the patients look ill, pallor, pulse persistently, height even during rest, features of shock, temperature may be slightly elevated. On abdominal examination, you can see a tenderness, mass in the lower abdomen, and colon size. It's a dark bluish discoloration if found suggests intraperitoneal hemorrhage. Diagnosis is a pregnancy test, positively more than 82%. Hematocrit, white blood cells count, a negative test does not rule out an ectopic gestations. Chronic ectopic blood examination, synthesis, estimation of beta HCG, sonography, color Doppler sonography, combination of quantitative beta HCG values and sonography laparoscopic. Dilatation and curettage, serum progesterone, and laparotomy. Management, emergency treatment, surgical treatment, medical treatment, and supportive treatment. This mean antibiotic, iron therapy, and high protein diet. So, unruptured tubal pregnancy. Only observation is done, hoping spontaneous resolution. Indications are initial serum HCG level less than 1000. Gestational sac size is less than 4 centimeters. No fetal heartbeat on TVC. No evidence bleeding or rupturing. So, conservative management is easier, medical or surgical. Medical management, drugs commonly used for salpinga synthesis are methotrexate, potassium chloride, prostaglandins, PGF2A, or actinomycin. So conservative is a surgery, linear salpingostomy, linear salpingotomy, segmental resection, femoral expression, and salpingectomy. Cervical pregnancy. Clinical diagnostic criteria is created by Rubin in 1983 for cervical pregnancies are soft enlarged cervix equal to or larger than the fundus. Uterine bleeding following amenorrhea without cramping pain. Products of conceptions entirely confined within and firmly attached to the endocervix. A closed internal cervical os and a partially opened external os. Sonography. Confirmation is done by histological evidence of the presence of villi inside the cervical stroma. Gestational thromboplastic disease. Definition is a term commonly applied to a spectrum of interrelated disease originating from the placental thromboplasm. Classification. So, we have several types of haditiformal, invismal, choriocarcinoma, and placental site thromboplastic tumors. So it's a modified classification. Haditiformal, complete, partial, invasive mole, placental site thromboplastic tumor, choriocarcinoma. It may be a non-metastatic disease or metastatic disease. Low risk, good prognosis. If a disease is present, less than 4 months duration. Initial serum HCG level, less than 40,000. Metastasis limited to lung or vagina. No prior chemotherapy. No presenting term delivery. High risk. It's a long duration of disease, more than 4 months. Initial serum HCG more than 40,000. Brain or liver metastasis. Failure of prior chemotherapy and following term pregnancies. Complications. About 1 in 1,000 ectopic pregnancy result in maternal death. Untreated or mistreated ruptured ectopic tubal pregnancy 8 till 12% of all maternal deaths. The majority of these deaths are preventable. Tubal damage is a chronic salpingitis, infertility or sterility. Interstitial obstruction may develop after hemiperitoneum and peritonitis. You can see it's a imagine of the hydrotherium molar, so molar pregnancy. You can see it's how we look at inside the uterus. It's the abnormal condition of the placenta where there are partly degenerative and partly proliferative changes in the young embryonic villi. We have two types, it's a complete and incomplete. So in this table, you can see is it different types of the molar pregnancy during the gestational age. The gestational is at 8 to 16 weeks complete, partial is at 10-22. Uterine size. The large of gestational is 33, and the partial is at 10. Small of gestational is 33, and the partial is at 65. Diagnosed by ultrasonography, commonly you can find is a complete and rare in the partial types of molar pregnancy. The lutein cyst is at 35% rare. Human gonadotropic therapy is more than 50,000. In partial, you can see is you can find it's less than 5,000. Malignant potential is more than 25%, and the partial is less than 5%. Metastatic disease is less than 5, and the partial is less than 1%. Gross findings include massively enlarged edematous villi that gives a classic grape-like appearance to the placental and like embryonic tissue. Pathologic features include hydroponic swelling in the majority of villi, accompanied by a variable degree of trophoblastic proliferations. You can see it's a complete Gid-Ati-deform mole, the classic snowstorm signs. You can find it by ultrasound research. Clinical features: vaginal bleeding, varying degrees of lower abdominal pain, constitutional symptoms, expulsion of grape-like vesicles per vagina in diagnostic of vesicular mole, history of quickening and absent. Signs: fetal signs at lower months of pregnancy are evident. The patients look ill, pallor in present, features of preeclampsia. Per abdomen, you can find the size of the uterus is more than the expected period of amenorrhea. The feel of the uterus is firm, elastic. Fetal parts are not filled. Absence of fetal heart sound. Vaginal examination, internal ballonment cannot be elicited in a lateral or bilateral enlargement. So invasive mole is the most common requirement of heated forum mole, representing 70 to 90% of causes of the persistence GDT. This discovery occurs when hydroponic chorionic villi are present with the myometrium, its vascular spaces, or at distant sites. The lesion has been known as chorion adenoma, spines, penetrating mole, malignant mole, and molar distress. Up to 20% of invasive moles metastasis to extrauterine, pelvic, and distant sites, like a lungs, vagina, vulva, or broad ligament. You can see it's ectopic pregnancy. It's a snowstorm appearance. Thank you for your attention. Thank you for your attention.